I'm Jana Migraines, and this is my presentation on migraines. So here's my case presentation. This is Will. He's a 44-year-old male with a history of migraines and hypertension, and the migraines are becoming more frequent and are starting to impact his job. He reports that he's had to stay home several times over the past few months because of them. He has tried some beta blockers in the past, but they were not effective. He is currently on diltiazem CD, 120 milligrams daily, and Imitrex 50 milligrams is needed daily for the migraine. He has no known drug allergies, and he has no other medical history or surgeries. His vital signs look like they're within normal limits, and his blood pressure appears to be well controlled on the diltiazem. The International Headache Society classification for migraines are those without aura, those with aura, and chronic migraines. There are also some others listed out, such as tension headache, trigeminal autonomic cephalgias, and other primary headache disorders related to infections or trauma. But I'm only covering migraines here. So migraine symptoms, those with an aura, or the classic migraine as it's known as also, has sensory disturbances, including flashing lights or vision changes, intense head pain, nausea, and sensitivity to light and sound. And these auras start about an hour before the head pain, and they last about an hour, or less than an hour, excuse me. Those without the aura are the most common. They last between 4 and 72 hours and have pain only on one side of the head, and it's a throbbing, pulsating pain that usually worsens with activity. Migraine causes are unclear. There are multiple theories of them. The neuronal theory is that there is depolarization of the cells, which is caused by excessive potassium, and that leads to depression of the neuronal activity, which in a cascade leads to the migraine symptoms. There's also the neurovascular theory, which is a complex series of neuronal and vascular events which initiate the migraine. There's also the cortical spreading depression theory, vasoactive substances and neurotransmitters. There's a migraine center theory, brainstem activation, and theories related to magnesium deficiency, endothelial dysfunction, dopamine pathways or hypersensitivity, and there's also a genetic component to migraines as well. So the diagnostic criteria for migraines, a patient has to have at least 5 attacks that meet 3 of the following criteria. They must last 4 to 72 hours. They must have unilateral location or pulsating quality, moderate to severe pain, and aggravated by routine activity. They also must have nausea and vomiting and be photophobic and phonophobic, light and noise sensitive. So treatment for these, there is prophylactic treatment for chronic treatment of the symptoms. There's intermittent prophylaxis for when the migraines are expected. And then there's symptomatic or abortive treatment during an attack, which is the mainstay of the treatment. And that is typically NSAIDs or acetaminophen for mild to moderate symptoms, narcotics and tramadol for something worse, and then triptans and ergoalkaloids for the moderate to severe attacks. And these tend to be the most effective medications. So our differential diagnosis for this gentleman is anything new or odd. So if they're old or chronic headaches, we're looking at tension or migraine or cluster headaches, TMJ, substance withdrawal, or cervical degenerative joint disease. If they're new, are they with a cough or exertional? Are they thunderclap? Are they due to infections or vascular? Is there a space-occupying lesion we need to worry about, such as a tumor or a hematoma? And our don't miss diagnosis is intracranial aneurysm. So back to Will. His past medical history, as I said before, has no surgical or medical history, no known drug allergies. He doesn't smoke. He drinks rarely on the weekends. The family history does include his mom and his brother who have had headaches in the past. So his physical exam and his neuro exam, they were normal. And because of that, we're not going to order any blood tests or do any MRIs or CT or lumbar puncture, which would help us rule out an intracranial aneurysm. So plan of care number 1 for Will, because his PE and neuro exam were within normal limits, we're going to stay within the same class. So we're going to switch to another triptan. We're going to try Triaxamet, 85 500 milligrams, which is a combination of sumatriptan and naproxen sodium. The adult dosage is usually 1 pill with a maximum of 2 pills in a 24-hour period. Side effects include dizziness, somnolence, nausea, chest discomfort, or pressure, and dry mouth. And there are GI symptoms, but they're very uncommon. So we'll just need to monitor his blood pressure. We may need to adjust his medications as it can cause his blood pressure to go up slightly. The pharmacotherapeutics of Triaxamet, it's a combination of sumatriptan and naproxen, and this combination is much more effective. Sumatriptan is a selective serotonin agonist, so it causes vasoconstriction. The CYP450 action is unknown, but it is metabolized in the liver and has a half-life of 2.5 hours. The naproxen is an NSAID. It is a 2C9 substrate of the CYP450. It's also metabolized in the liver, and it's a COX inhibitor. Interestingly, the price on this is quite expensive. GoodRx quoted me a price of $200 to $300 for only 9 tablets. However, when you break these pills down separately, they're really quite inexpensive. The naproxen for 60 tablets is about $20, and the sumatriptan is it's like $12 for 9 pills. So a huge jump in price in this. Adverse reactions that we have to watch for on this, there are some life-threatening arrhythmias that it can cause. It can cause heart failure. It can cause some major ischemic events in the brain and in the bowel. There was a huge list. Side effects for him to watch out for are dizziness, somnolence, the nausea. So the dosing for an acute migraine would be 1 tablet and repeat it in 2 hours. If it's not effective, maximum dose is 2 tablets in 24 hours. You do not crush, chew, or cut those, and take them with food. Contraindications for this medication would include any sort of ischemic disease, cardiac or bowel, uncontrolled hypertension, peripheral vascular disease, and any hepatic impairment, since they're both metabolized in the liver. If he has a history, then we want to do a chem profile or a CBC just to keep an eye on that. There are black box warnings with this medication, as NSAIDs do increase the risk of fatal cardiovascular thrombotic events and GI events, such as bleeding or perforated intestine. So plan of care number 2 is sort of the do no harm or do less harm version of it, which would be to increase his Imitrex dose and to add some multivitamins, such as the magnesium and the B12, and maybe some coenzyme Q10, to start a migraine diary to track some of his triggers and see if these changes were effective, and to make some lifestyle changes. Perhaps, his new job, maybe it's causing him some serious stress, or it's having him spend more time on the computer and causing some eye strain. Things like that we may need to look into. Other treatment ideas would involve some other medications. So the beta blockers, those would be used as a preventative treatment. Anti-epileptic medications and antidepressants, they affect the serotonin levels, and some patients with headaches, chronic headaches, do have altered levels of those. The CCBs and the ACEs, they would also be used prophylactically, and the coenzyme Q10 supplements, those would help to prevent inflammation and perhaps prevent some flare-ups of the migraines. On a side note, and only because my daughter has had multiple migraines over the past several years, I might consider an ophthalmology consult. Also think about, because of the increased screen time perhaps with his new job, there's some eye strain, perhaps some extra blue light exposure, which is triggering these headaches. There are glasses which filter out the blue light, which may be very helpful for him. And also, changing his habits to reduce his stress and reduce some of those triggers. And that concludes my presentation. Thank you very much.